Hip dislocations are true orthopedic emergencies. Timely reduction of hip dislocations, preferably within 6 hours of trauma, is crucial for reducing the likelihood of avascular necrosis. Posterior hip dislocations are much more common than anterior ones. Patients with posterior dislocations generally present with a flexed, abducted, and internally rotated hip. Conversely, patients with anterior dislocations generally present with an extended, mildly abducted, and externally rotated hip. AP radiographs of the pelvis or hip are usually diagnostic. In this AP pelvis X-ray, the head of the prosthesis is clearly dislocated from the acetabulum. In the lateral projection, the presence of a posterior dislocation is confirmed as the prosthetic femoral head lies posteriorly in the direction of the ischial tuberosity. Prior to any reduction maneuver, perform a thorough neurovascular examination of the affected extremity. Check for femoral, popliteal, dorsalis pedis, and posterior tibial pulses. Additionally, perform a complete neurological examination, including sensory and motor function. Special attention should be paid to the motor function of the extensor hallucis longus and flexor hallucis longus, since these muscles are innervated by the sciatic nerve, which may be injured in a hip dislocation. Patients may require pre-medication, including procedural sedation and analgesia, prior to reduction of the hip dislocation. This determination must be made on a case-by-case basis. Position the patient supine on the stretcher. Instruct an assistant to apply downward pressure on the patient's pelvis to provide countertraction. Her hands should be placed on the patient's anterior superior iliac spines. Grasp the patient's ipsilateral knee with both hands. Hold the patient's leg in adduction with the knee flexed. Apply axial traction to the femur in line to the deformity and gently flex the hip to 90 degrees. Next, gently rotate the hip internally and externally until reduction is achieved. Successful reduction is usually heralded by a palpable clunk. Once the hip is reduced, take the hip through a range of motion to assess stability. Note that considerable force may be required to complete the reduction. You may need to stand on the bed with your legs straddling the patient's legs in order to obtain the proper mechanical advantage. The assistant may also apply a lateral force to the proximal thigh to assist reduction. Patience and continued traction are generally required for this and all other reduction maneuvers. With time, the patient's muscles will fatigue and generally allow reduction. Position the patient supine on the stretcher with both knees flexed to approximately 130 degrees. Stand beside the dislocated leg, place your elbow under the ipsilateral knee, and grasp the contralateral knee. Instruct an assistant to apply downward pressure on the patient's pelvis to provide countertraction. Her hands should be placed on the patient's anterior superior iliac spines. Place your free hand on the patient's ipsilateral ankle and immobilize it against the stretcher. Using your arm as a lever, elevate the ipsilateral knee by raising your shoulder. The upward force applied through the dislocated hip is countered by an opposing force to the contralateral leg. Successful reduction is usually heralded by a palpable clunk. Once the hip is reduced, take the hip through a range of motion to assess stability. The modified Alice maneuver for anterior dislocations is analogous to the method used for posterior dislocations, except that the knee is held in abduction during the procedure. Place the patient in the supine position. Instruct an assistant to apply downward pressure on the patient's anterior superior iliac spines. Grasp the patient's ipsilateral knee with both hands. In the modified maneuver for anterior dislocations, hold the leg in abduction with the knee slightly flexed. Apply longitudinal traction to the femur in line to the deformity and gently adduct and internally rotate the hip until reduction is achieved. Successful reduction is usually heralded by a clunk. Once the hip is reduced, take the hip through a range of motion to assess stability. Re-examine the patient after the reduction maneuver. Take the hip through range of motion to assess stability. Repeat and document a complete neurovascular examination. Obtain post-reduction radiographs of the hip to assess for successful reduction and concomitant fracture. Immobilize patients with posterior dislocations with a simple knee immobilizer. This will prevent the patient from flexing the hip, which may cause recurrent dislocations. For anterior dislocations, an abduction pillow may be helpful. Consultation with an orthopedist should be obtained prior to patient disposition to arrange for definitive care.